Imagine waking up with this really painful rash, blistering, maybe just on one part of your body.
Hmm.
Normally you'd think, right, call the GP, maybe even call 111 if you're really worried.
Sure, that's been the standard path.
But things are changing quite significantly, actually, in primary care across England. There's this thing called NHS England's Pharmacy First service.
It's a big development.
And it means you might now be able to just, well, walk into your local pharmacy, get checked out for something like shingles, and potentially even get antiviral treatment right there.
It's about using those clinical skills that pharmacists have right there in the community, making access, easier.
Exactly. And today, that's what we're diving into. Shingles specifically within this Pharmacy First service.
Yeah.
We've got the official patient group directions, the PGDs. These are basically the rule books pharmacists use for giving out antivirals, like aciclovir and
Detailed protocols, yes.
Yeah.
Very important document.
And we also have a really useful article, kind of like top tips for health professionals managing shingles under this service.
So our mission today is really to unpack these sources for you. We want to get into the nitty-gritty of how it works for shingles, who exactly qualifies for this pharmacy treatment under the PGDs.
And what that assessment by the community pharmacist actually involves, it sounds quite detailed.
It really is.
And this isn't just a pilot, it's rolling out across England, places like Berkshire, all over.
It's a national service.
Which, honestly, setting this up sounds like a huge undertaking. So much work behind the scenes.
Absolutely. Training, new processes.
So we really have to give a massive shout out and thank you to the community pharmacists, especially those in Thames Valley that we know are working incredibly hard. But really, pharmacists everywhere across the country, they're making this happen.
Hear, hear. It's a true team effort across the NHS. Integrating these services requires everyone pulling together. Community pharmacy is just so vital now.
Okay, let's get into it then. Let's start with shingles itself. What exactly is it, and why is treating it quickly so important that we need this kind of pharmacy access?
Right. So shingles comes from the varicella zoster virus. That's the same virus that gives you chickenpox.
Okay, I didn't realize it was the same one.
Yeah. After you recover from chickenpox, the virus doesn't actually leave your system. It sort of hides away, lies dormant in your nerve roots for years.
Just waiting. That's slightly unsettling.
It is a bit. Then sometimes maybe if your immune system is a bit lower or for reasons we don't always fully understand, it wakes up, reactivates.
And that's shingles.
That's shingles. The reactivated virus travels down the nerve pathway to the skin supplied by that nerve.
And that leads to the symptoms, the rash.
Usually, yes. It often starts with a sensation, tingling, maybe itching, sometimes quite a sharp burning or stabbing pain. And it's typically just in one area on one side of the body.
Following that nerve path you mentioned, dermatome, is that the term?
Exactly, a dermatome. The sources actually show diagrams of these. Then, a few days after the pain starts, the rash appears in that same spot. Red patches, then blisters, fluid-filled vesicles, which eventually crust over.
So pain first, then a very localized rash on one side. Got it. If it eventually heals up on its own, why the big push for antiviral treatment, especially early on?
Good question. While the rash often does resolve itself, particularly in younger, healthier adults, treatment has two main aims. First, it can speed up healing, reduce the severity of the rash and the pain during the acute phase.
Okay, makes sense.
But the second aim, and this is really crucial, especially for older people or those with other health issues, is to reduce the risk of a complication called postherpetic neuralgia, PHN.
PGen, that
Yep.
sounds not good. What is it?
It's persistent nerve pain. It can linger in the area where the rash was long after the blisters have healed completely. Weeks, months, sometimes even years.
Years. Wow.
Yeah, it's basically nerve damage caused by the virus during the shingles outbreak. The sources really stress how difficult PHN can be to treat and how much it impacts quality of life, sleep, mood, everything. So preventing or reducing the severity of PHN is a major driver for early antiviral treatment in eligible patients.
Okay, that makes the urgency much clearer. It's about avoiding that long-term, hard-to-treat pain. So let's link this back to Pharmacy First. How does this service, using these PGDs, enable pharmacists to help?
Right, so Pharmacy First empowers accredited community pharmacists in England to manage 7 specific common conditions. Shingles is one of them. It means they can assess you and, if you meet the criteria, supply NHS treatment directly. No need for a separate GP appointment and prescription in those cases.
Streamlining things. And the PGDs, the patient group directions, are the key.
They are the legal framework. They authorize the pharmacist, who is a registered healthcare professional, to supply a particular medicine, like an antiviral for shingles, to a patient who fits a very specific description without an individual prescription.
So it's like a highly detailed protocol they have to follow.
Exactly. Very strict inclusion and exclusion criteria. If the patient ticks all the right boxes in the PGD, the pharmacist can supply the medication.
Who puts these incredibly detailed documents together? It sounds like a massive task.
It is. These shingles PGDs weren't just whipped up overnight. The sources show they were developed by a dedicated working group, lots of peer review. You've got senior doctors, chief pharmacists, microbiology specialists involved.
Microbiology, like Professor Mark Wilcox, I saw his name mentioned, National Clinical Director for AMR and IPC.
Yes, exactly. Antimicrobial resistance and infection prevention and control. His involvement and others with that expertise is really important.
Why specifically for shingles antivirals?
Well, antimicrobial stewardship, making sure we use antimicrobials like antivirals wisely, is critical. We need to avoid resistance developing. So having AMR and IPC experts help design the PGDs ensures the criteria for treatment are clinically sound, targeting the patients who will benefit most and avoiding unnecessary use. It's built right into the framework.
That's really smart. Responsible prescribing from the get-go. And these PGDs, they have expiry dates.
They do. They need regular review and updates. The ones we looked at run from January 2024 to January 2027, for example. Pharmacists always have to work from the current version.
Right. So picture this. Someone walks into the pharmacy. They think they have shingles. The pharmacist has the PGD. How do they figure out if that person is eligible for treatment right there? What are they looking for?
Okay, this is where it gets very specific, based directly on the PGD criteria. First, the patient has to be 18 or over. Then the timing of the rash is critical.
How critical?
Well, if the rash started within the last 72 hours, so 3 days treatment under the PGD is generally indicated if something else applies too, like if the patient is over 50 years old,
Okay.
or if they have moderate to severe pain. The pharmacist might use a simple scale to assess this.
Yeah.
Or if the rash itself looks moderate or severe, maybe the blisters are merging together, confluent they call it. Or another trigger within that 72-hour window is if the rash isn't on the main trunk of the body, say it's on the neck, an arm, a leg, or down in the perineal area.
So under 72 hours PLUS, age, pain, rash severity, or location. What if it's been a bit longer, say 4 or 5 days?
There's still a possibility for treatment up to 7 days after the rash started, but only under specific circumstances.
Which are?
Treatment might still be okay between 72 hours and 7 days if new blisters are still actively forming, or if the pain is severe, or if the person's considered at high risk of getting severe shingles, perhaps because they have another condition like severe eczema, or simply if they're age 70 or over.
Ah, that higher age threshold again, linking back to PHN risk.
Yeah.
Makes sense. What about people with weakened immune systems? Immunosuppression.
That's handled very carefully in the PGDs. For example, the valaciclovir PGD does allow treatment for some immunosuppressed individuals, but specifically not those classified as severely immunosuppressed.
Okay, a distinction there.
Yes. And for those less severely immunosuppressed patients, they might be eligible if the rash started within 7 days, but only if the rash isn't widespread or looking severe, and if the person feels generally well systemically. The aciclovir PGD actually points towards considering valaciclovir for immunocompromised patients who meet the criteria.
So the pharmacist is assessing immune status too.
Definitely. It's a key part of the consultation.
So putting it all together for someone listening who might experience this, the pharmacist is basically running through a detailed checklist based on these PGDs.
It's more than just a checklist. It's a clinical assessment guided by the PGD. They'll ask about when the rash started, exact location, pain levels, how it looks, your general health, past medical history, any immune issues. They're matching your specific situation against the detailed criteria in the PGD to see if you fit the profile for treatment under this service.
And crucially, they also need to know when not to treat, when to send someone elsewhere. What are the main reasons someone would be excluded and need referral?
Yes, the exclusion criteria are just as important for safety. The PGDs list them very clearly. If any apply, the pharmacist cannot supply the antiviral under the PGD.
Like what?
Obvious ones first. Anyone under 18. If you're pregnant, or think you might be. Or if you're breastfeeding and actually have shingles sores on the breast itself.
And that severely immunosuppressed category you mentioned.
Absolutely, a key exclusion. These patients need specialist oversight. The PGDs give examples: certain leukemias or lymphomas, recent transplant recipients, people with HIV and very low CD4 counts, those on high-dose steroids long-term, or strong biologic drugs, or undergoing certain cancer treatments.
So very specific groups needing different care pathways.
Precisely. Also excluded are immunosuppressed individuals whose rash is widespread or severe, or if they're generally unwell. Then there are things like known severe allergies to the antivirals themselves. If the rash started more than 7 days ago and none of those special 7-day criteria are met, if you physically can't take or absorb tablets, there's a mention of a rare reaction called DRESS with valaciclovir. And a really critical one, any suspicion that the shingles is affecting the eye area.
Ah, the eye. That sounds serious.
It is. If the rash is near the eye, especially if it's on the tip or side of the nose, it's called Hutchinson's sign, or if there are visual symptoms or an unexplained red eye, that's an immediate exclusion and needs urgent ophthalmology assessment to prevent potential sight loss.
Definitely one for the specialists. Any other major red flags?
Yes. Any signs of potentially serious complications, things suggesting the infection might have spread, like meningitis or encephalitis symptoms or facial paralysis like Ramsay-Hunt syndrome, and critically important, any signs that might suggest sepsis or a severe systemic infection. That's an emergency.
So the pharmacist is doing a really important safety check, identifying people who need urgent or specialist care.
Exactly. A few others include people at risk of dehydration who aren't managing fluids, those with significant pre-existing kidney problems. The PGDs specify the exact stages of chronic kidney disease that are excluded for each drug, and people taking certain interacting medicines like cyclosporin, tacrolimus, mycophenolate, or theophylline.
That's a comprehensive list. So if you fall into any of those exclusion categories, what happens? Where does the pharmacist send you?
The PGD guides the referral. For those serious things, suspected sepsis, severe complications, severe immunosuppression with a bad rash, or feeling unwell, it's likely an immediate referral, probably calling an ambulance for A&E.
Right.
For other urgent issues like suspected eye involvement, pregnancy, uncontrolled pain, or just feeling generally unwell without sepsis signs, it would be an urgent referral to a GP or the relevant specialist, depending on the local setup. For other exclusions, it's referral back to their GP or another appropriate practitioner.
Okay, so it's either a safe treatment in the pharmacy or safe referral onwards. Now, if someone is eligible, there are two antiviral options mentioned, aciclovir and valaciclovir. How does the pharmacist pick which one?
Good question. Aciclovir is generally positioned as the standard choice within its PGD. The dose is quite high, 800 milligrams 5 times a day for 7 days.
Wow, 5 times a day. That sounds like it could be tricky to stick to perfectly.
It can be. You're looking at taking a tablet roughly every 4 hours while you're awake. And that dosing frequency is actually a key factor in the decision-making process, according to the sources.
Ah, so that's where valaciclovir fits in.
Exactly. Valaciclovir is the alternative, available under its own PGD. The dose is 1 gram 3 times a day, also for 7 days. Much less frequent.
So when would they choose valaciclovir over the standard aciclovir?
The valaciclovir PGD specifically allows its use not just based on the rash timing and severity criteria we already discussed, but also in situations where adherence to that 5 times a day aciclovir regimen might be difficult.
Such as?
The PGD gives examples. Someone who needs help taking their medicines, maybe they have carers visiting, and organizing 5 doses could be impractical. Or someone who's already taking a lot of other medications. The PGD mentions 8 or more prescribed medicines a day, where adding another frequent dose could compromise their adherence to everything.
That makes practical sense.
The aciclovir PGD itself says these patients should consider valaciclovir. The Top Tips article also flags this adherence risk. And remember, valaciclovir is also an option under its PGD for those specific, non-severely immunocompromised individuals we mentioned earlier. Oh, and the aciclovir PGD also refers to valaciclovir if there are supply problems with aciclovir itself.
So it's quite nuanced. The pharmacist is using the PGDs not just to say yes or no to treatment, but also to tailor which treatment based on the individual's circumstances and ability to manage the medication schedule.
It really demonstrates that clinical judgment within the defined framework. It's not just ticking boxes. It's applying the guidelines thoughtfully to the person in front of them.
Okay, antivirals are key, but shingles is often really painful. What else can the pharmacist advise for managing the pain?
Yeah, pain relief is a big part of the advice. The sources say pharmacists should recommend standard over-the-counter options like paracetamol, maybe co-codamol if appropriate, or ibuprofen, assuming no contraindications for the patient.
And if that's not enough?
They'd advise seeking further medical help if the pain isn't controlled. Interestingly, the patient information leaflet from the British Association of Dermatologists, which pharmacists are advised to give out, suggests trying things like over-the-counter lidocaine 5% ointment or potentially asking a doctor about prescribed capsaicin cream later on if needed.
What about just looking after the rash itself? Any self-care tips?
Definitely. Providing the BAD leaflet is key. Other advice includes keeping the rash clean and dry to prevent bacterial infection getting in. Importantly, avoid putting creams or sticky dressings directly on the blisters, as that can actually delay healing. Staying well hydrated, especially important for older people, and wearing loose, comfortable clothing over the area to avoid irritation are also standard recommendations.
And what about passing it on? You hear conflicting things. Can you actually catch shingles from someone?
That's a really common misconception. You cannot catch shingles from someone with shingles. Shingles happens when the chickenpox virus you already have reactivates.
Right, the dormant virus waking up.
Exactly. However, and this is the important bit, if someone has never had chickenpox or the chickenpox vaccine, they can catch chickenpox from the fluid in the shingles blisters.
Ah, so the risk is spreading chickenpox, not shingles.
Precisely. The person with shingles is infectious, potentially spreading chickenpox virus from when the blisters appear until they've all crusted over, usually about 5 to 7 days.
So who needs to be careful around someone with shingles?
The advice is to avoid close contact with people who might be vulnerable to severe chickenpox, especially if the shingles rash is weeping and can't be reliably covered up. This includes pregnant women who aren't immune to chickenpox, people with severely weakened immune systems, and very young babies, particularly those under a month old.
And general advice?
Good hand hygiene is important, washing hands often. Don't share towels or clothes while the rash is active. In terms of work or school, if the rash is weeping and can't be covered, it's best to stay home. But once it's dry and crusted, or if it's in a place that's easily covered by clothing, then it's usually fine to go back.
That's clear advice. Now, what about follow-up? What safety netting advice does the pharmacist give? When should someone seek more help after starting treatment?
This is absolutely crucial. The pharmacist needs to give clear when-to-worry advice. Generally, seek medical advice if the symptoms haven't cleared up within about 4 weeks. Also, get help sooner if symptoms suddenly get much worse, or if they just don't seem to be improving after finishing the 7-day antiviral course, or if new blisters keep appearing after day 7 of treatment. And definitely if the pain is still really bad and not managed by the painkillers.
And the emergency red flags.
They reinforce the need to get immediate medical attention, call 911, or go straight to A&E if any signs of sepsis develop. The sources really stress this, particularly for anyone immunocompromised who starts feeling systemically unwell or whose rash gets significantly worse or spreads rapidly. They need urgent assessment.
So, clear boundaries for self-management and when to escalate. Is there anything discussed about preventing future episodes?
Yes, the shingles vaccine. It's mentioned as a key way to reduce the risk of getting shingles again and also making PHN less likely or less severe if you do get it.
Who can get that?
Eligibility is based on age. Primarily, the sources mention the current cohorts, like those aged 70-79, people turning 65 from September 2023 onwards, and also severely immunocompromised individuals age 50+. The pharmacist would advise someone who's just recovered from shingles to talk to their GP practice about getting vaccinated once they're better, if they fall into an eligible group.
Right, connecting current treatment with future prevention. How is all this interaction recorded? Does the patient's GP find out they've been treated at the pharmacy?
Yes, documentation is rigorous. Pharmacists have to keep detailed records of the whole consultation. Consent, patient details, exactly how they met the PGD criteria, why they didn't. Relevant history, allergies, what medicine was supplied, when all the advice given, and any referral details.
Thorough. And communication with the GP.
Essential.
A notification must be sent to the patient's GP practice, ideally electronically via a structured digital message. This should happen the same day or the next working day. If digital isn't an option, NHS mail or even a paper copy can be used. And if the pharmacist identifies something the GP needs to act on urgently, they send a specific urgent action message.
So the loop is closed, the GP record stays up to date. We touched on antimicrobial stewardship earlier with the experts involved in the PGDs. How does this whole pharmacy first process for shingles actually contribute to that stewardship in practice?
Or if you look at the whole thing, the very specific inclusion criteria ensuring only appropriate patients get treated, The strict exclusion criteria diverting complex cases, the careful consideration of which antiviral to use based on adherence factors, the mandatory referrals, it's all guided by those expert-developed PGDs.
Right.
This means antivirals are being used more judiciously, only when indicated, only when likely to be most effective, and avoiding unnecessary exposure. It directly supports the goals of antimicrobial stewardship, using these precious medicines wisely to preserve their effectiveness and combat resistance. It's stewardship embedded in the service design.
So it's delivering accessible care and responsible prescribing. A win-win.
That's the aim, absolutely.
Okay, this has been a really comprehensive look. We've seen community pharmacists working under these very detailed PGDs and using clinical guidance, really stepping up as key providers for conditions like shingles via Pharmacy First.
They're doing that full assessment, checking eligibility meticulously, choosing the right drug, considering individual patient factors, giving that vital self-care and safety netting advice. It's a whole package of care delivered locally.
It really highlights that NHS team effort we mentioned earlier, and once again, a huge thank you is deserved for the community pharmacists like those in Thames Valley and right across England
Right.
for embracing this expanded role and making these services work.
Absolutely. And for pharmacists listening, wanting even more fine-grained detail on the PGD criteria or operational aspects, the strong advice from the sources is to check the official resources, like the CPE website, and read those full PGD documents thoroughly. Accuracy is paramount.
Definitely. And thinking about this, it leads to a really interesting point for the future, doesn't it?
Yeah.
As services like Pharmacy First potentially grow, covering more conditions, think about the increasing level of clinical skill and complex decision-making happening right there in your local community pharmacy. How does having this expertise so accessible change things for patients? And what could it mean for the whole shape of primary care in England going forward?
That's a big question. It certainly suggests a continuing evolution in how and where people access healthcare.
Something to ponder. Well, that's it for this deep dive.
Until next time.